All right, sounds good. Let's go.
All right, guys, welcome to the high yield renal review here with Strudel Med Student Reviews. My name is Tate. I'm here with Mike and with Xander. We're going to kind of go through all this content here. It's good for any like internal medicine shelf exam, any MBME standardized exam. Renal does tend to kind of cross over into a lot of other systems. So it's good to kind of have a base for just renal and kind of apply it to the rest of the fields as well. As we'll go through, we'll try to build some network thinking for you guys. So just to kind of start off, can you guys tell me a few like general physiologic things that the kidney does for the body?
So I know, the main one is making urine, so like filtration, and that includes like removing toxins. I know that in the proximal convoluted tubule, that's where EPO is produced. So red blood cell production, erythropoiesis. Um,
Wow,
so we've got filtration, erythropoiesis, like vitamin D activation happens in the PCT as well.
very good.
Fluid balance, we got to go through the kidneys to do diuresis. And then, like medication excretion, but that's part of filtration. Those are the main ones. I'm probably missing a couple, but
Yeah, you basically hit everything. We have our filtration, which is mainly our removing waste, and that's kind of how we measure kidney function is looking at waste products with creatinine for the most part. It's a surrogate measure of kidney function. But yes, also fluid balance, ADH and aldosterone both play a role there. Acid base balance, as far as like getting rid of hydrogen or bicarbonate as needed. Um, Hormone production, like you mentioned with EPO, stimulating RBC production. Renin, as far as our like blood pressure control, also can play a role here. And then, like you mentioned, vitamin D activation, the proximal convoluted tubule with 1-alpha hydroxylase. So as we kind of go through here, just kind of keeping all these things in mind that when we have kidney disease, some of these functions or all of these functions will be compromised and will be kind of left to deal with the consequences of those things. So we'll kind of get right into the first kind of bit of this, which we're going to start with some pharmacology with diuretics. Diuretics are very, very high yield because they're very, very common both in the hospital as well as like specialized uses and just like in the clinic. So we'll kind of start with carbonic anhydrase inhibitors, kind of a weird class of medications that doesn't always get used. So we have acetazolamide, kind of the prototype in this class. They act to block carbonic anhydrase in the proximal convoluted tubule. You excrete more sodium, bicarb, and chloride. Biggest note there is the bicarb excretion because it's a very unique function of specifically the carbonic anhydrase inhibitors. So with those, what kinds of side effects are at least highly tested, if you know, Mike?
so, the side effects. So it's normally used in like, is it idiopathic intracranial hypertension? And
Definitely, that's
then
one of them.
it's also used, is it acute angle glaucoma?
Yep, you can decrease the intraocular pressure with the acetazolamide, sure.
So the side effects, oh man. Um,
Kind of a tough one.
is it dizziness? Can it cause like,
I'm sure it does. I don't have it listed because it's a diuretic, and at the end of the day, probably the most common effect of all diuretics is going to be a little bit of hypovolemia, lower blood pressures.
I
But
don't
what I was going
remember.
for, at least for the purpose of exams, is this type 2 renal tubular acidosis. Um, the reason why this matters is because not many things cause a type 2 renal tubular acidosis, a proximal tubular acidosis, and that presents with a non-anion gap metabolic acidosis. So that's important because when you have anagma, your differential is very limited. So if you do see this on an exam and they, obviously calculating the anion gap from sodium minus the sum of both your chloride and your bicarbonate, if you have a non-anion gap metabolic acidosis and they give you in the history an indication why they would have maybe been taking carbonic anhydrase, like you had mentioned, maybe they had acute glaucoma or had idiopathic intracranial hypertension, whatever the case is, they might be trying to go after a side effect and specifically the renal tubular acidosis. And then there's also this like paresthesia neuropathy type picture that it's known to cause. So how about unique uses? You already mentioned a couple of them. There's a couple other ones that are, or at least one more that's very, very high yield
So
for board exams.
altitude sickness, is that the one?
Bingo, that's it. So yeah, acute altitude sickness, um, but specifically not like high altitude, like cerebral edema or pulmonary edema. Those acetazolamide does not really play as much of a role. But as far as the primary like altitude sickness, this one would be kind of what you would reach for. You mentioned acute glaucoma and intracranial hypertension, both very good thoughts and common uses for this, as well as like alkalizing the urine to help with cystine stones. Because in general, like we talked about with the mechanism of action up top there, if you're going to excrete more bicarbonate of the urine is going to become more basic. So you will alkalize the urine that way. So that's pretty good. I would really emphasize the type 2 RTA, emphasize the uses of acetazolamide, but really one of the lower yield of the diuretics. So kind of moving on to another kind of lower yield diuretic class, the osmotic diuretics. So this is really basically just osmotic substances that draw water into the nephron, into the collecting tubules that way. So uses of osmotic diuretics, pretty limited.
Yeah, I've essentially only seen these used or tested for trying to reduce intracranial pressure and like same with
Yeah,
like
and that's the only
hypertonic
thing
state.
I've seen on it as well. So um, just by virtue of having higher osmotic or oncotic pressure within the blood, you're going to draw fluid from the extravascular space, which would be good in the case of like intracranial pressure increases. Um, so I would keep those in mind. Obviously, if there was a hemorrhage and you were bleeding into the brain, you would not want to give an osmotic diuretic, as that would just leak out there into the tissue and draw more fluid with it. So it would worsen things in that situation. But in the case of intracranial pressure increases, it's a good choice. So as far as keep going here, probably one of the most common, if not the most common one that we see, at least in the hospital for sure, is loop diuretics. Furosemide, torsemide, bumetanide, or Bumex. They actively block the NAK-Cl transporter in the thick ascending loop of Henle. Increased excretion of these ions results in increased urine production, decreased blood volume. So kind of like our textbook diuretic effect, just prevents you from reabsorbing the ions, and that draws the water with it. So let's talk side effects of loop diuretics, Mike.
So
Just rattle them off.
yeah, the main loop diuretics we already mentioned them, but furosemide, Lasix, torsemide. What is torsemide? Uh, and
Oh, I
then
forget.
Bumex.
Yeah.
So so the main side effects you're gonna get. So these are the most powerful. So diuretics, the NKCC inhibitors. So these can cause obviously fluid deplete intravascular fluid depletion, but that's kind of an expected side effect. But some of the ones that boards like to test, I remember ethicronic acid's a loop diuretic too. I think we forgot to put that
Yes, it
on,
is.
but it's like the sensory neural hearing loss is
Mm-hmm.
one of the side effects. And then some of the loop diuretics are sulfa drugs like Lasix, but ethicronic
Mm-hmm.
acid notably is not a sulfa drug. So in patients with sulfa allergy, they could have a theoretical risk of allergy with like Lasix. Those are the main ones I can think of. And then obviously the because you're blocking the transporter, the NKCC transporters, there are co-transporters on the loop of Henle that, are for things like magnesium is in particular and also potassium. So you could lose those through the urine. So,
Yeah,
some
very nice. I think you
electrolyte
hit most
derangement.
most everything. The ototoxicity is high yield because there's not many drugs that cause ototoxicity. The sulfonamide toxicity, as far as specifically with Lasix and using ethicronic acid as a backup in cases where people, they would have given you a history in the test question about an anaphylactic reaction to a sulfa drug in the past. And then the ones that we actually kind of battle in the hospital a lot, these patients with congestive heart failure where we're actively diuresing, we're also usually having to replete potassium and magnesium as we draw it off of them with these high powered diuretics. So, and especially in those patients are already at risk for more arrhythmias with their heart function anyway. So just important clinically to keep an eye on electrolytes, specifically potassium and magnesium, in cardiac patients with on diuresis. And then the hyperuricemia, same way with any like source of hypovolemia, as you concentrate the blood or hemoconcentration, that can manifest as hyperuricemia with associated gout. So kind of moving on to the thiazide diuretics. So they block sodium reabsorption specifically in the distal convoluted tubule, and therefore increase urine output. So as far as more side effects, um, very similar side effect profile, but thiazides have a few kind of like higher yield side effects, and we'll just kind of go over them. So rather than like rather than just a lot of like hypo things, I usually think of the thiazides actually do increase a few things, specifically like metabolic syndrome type things. They can cause a little bit of hyperglycemia, hyperlipidemia, hyperuricemia. Hyperuricemia more due to the volume contraction effect that we had talked about. But what's really high yield for the purposes of exams is that thiazides can be tied to like increased incidence of pancreatitis. Just one of the drugs that increases the risk of pancreatitis. There's a lot of drugs that are implicated in that. But thiazides are one of the more common ones that have been known to cause it. And then the hypercalcemia, which is kind of important because it can be used in certain instances. So that's kind of my next question is like, what's a good time to use a thiazide diuretic or some comorbid conditions where you'd consider reaching for a thiazide?
Yeah, so I think I remember an acronym for the thiazide diuretics, the side
Go
effects.
off.
It's hypergluc, GLUC. And it basically helps you remember what else becomes elevated as a
Oh,
side
good.
effect of
Yeah.
thiazide diuretics. So it's hyperglycemia, hyperlipidemia, hyperuricemia, and then hypercalcemia.
Yeah, that's very good.
Some good
Um,
times to use it that I can remember are so you get hypercalcemia because you're reabsorbing calcium from the urine. So in patients that
yeah.
are more high risk for like calcium oxalate kidney stones, and then it's also a first line medication for hypertension.
Very nice. Very nice. So yes, it's a first line drug for hypertension, which makes it incredibly high yield because it gets used in the clinic a lot. There is this theoretical benefit for people with osteoporosis because you'll increase the calcium levels that way, the same way you tell them to supplement calcium and vitamin D. These people with low bone density, you can get a little bit of that. So if you had an older lady specifically is the demographic they like to reach for, has a DEXA scan with a T-score less than 2.5, also has a little bit of hypertension that you could treat with a first line agent. It wouldn't be a bad choice to go for the thiazide and maybe get a little bit of bone density effect. And then, like you mentioned, the calcium stone disease, especially when they become recurrent, you're looking for ways to reduce the calcium load in the urine at once. So this would be a good way to do that as well. So how about in the same, like these are good times to use it. What about a bad time to use? What other medication would you not want to use a thiazide with?
Oh, this is a tough question.
This is a tough question because it's kind of read my mind. It's not very specific. How about a
Uh,
psych med?
thiazide. Oh, is it lithium?
Very good. So the way I've always thought about it is lithium, if you look at the periodic table, is very, very similar to sodium in molecular structure, or in atomic structure, I should say. So in the same way that I'm trying to think how it works. I think it's because something with like how the sodium transporter that you're blocking is the same one that would normally be able to excrete lithium as well because the ions are so similar. So therefore you don't clear lithium as well when you use a thiazide diuretic. So there's this increased risk of nephrogenic diabetes insipidus, which is one of like the kind of end results of lithium toxicity, but also just general lithium toxicity, which a lot of times on exams that's like GI distress, tremor, some kind of vague side effects, but they'll tell you that they're taking lithium. And then maybe they added a drug for hypertension recently in the clinic. But what should be noted is that if you have nephrogenic diabetes insipidus, but it's not lithium induced, thiazides are actually the treatment for that. So it's kind of tricky because you can identify NDI, but if it's lithium associated, you do not want to give a thiazide. Um, you would actually want to give a different medication, and I have that as a question later on. But just kind of a high yield tidbit because it's two very common medications, like lithium very common in the psych setting, thiazides very common in the general medicine setting. So that interaction is pretty high yield, and lithium toxicity can be dangerous. So with that, we'll kind of move on to potassium-sparing diuretics, so otherwise known as the MRAs or the mineralocorticoid receptor antagonists. So spironolactone, eplerenone, and amiloride, they block action of aldosterone in the DCT, and specifically amiloride and triamterene. They're still potassium sparing, but they specifically work further down on the ENaC channels that are further in the nephron. So one is like the MRA receptor antagonist, and one are the ENaC antagonists, but they're both considered potassium sparing diuretics. So side effects of those,
Hyperkalemia.
yeah, that's the big one. The other
And
very
then
specific
wait,
one is spironolactone.
yeah, spironolactone, funny enough, is actually very well. There are a couple newer indications since when I remember I helped make this
Yeah,
PowerPoint at least, but one is well, not newer, but newer to me. Not really it as high yield, but I've seen it tested more and more. But the anti-androgenic effects of spironolactone are actually commonly kind of mobilized for things like PCOS, but also acne, like especially hormonal acne,
Interesting.
and also, of course, for GDMT in heart failure.
Yeah, so just another reason, when I was first learning this and I hadn't quite got into my rotations yet, hadn't really seen many people's medical recommendations. I'd been told that, the potassium sparing diuretics, they're good to use if people have like a history of hypokalemia with like the thiazides with the loops, or you can't afford to give them more hypokalemia for whatever the reason. But really the diuretic potency of them is not all that great compared to the other agents. Um, so the fact that now they have mortality benefit in heart failure and can be used for like anti-androgen uses really kind of broadens the context in which you'll see this. So side effects, yes, hyperkalemia, which is dangerous. It might just be a setup for them to test you on, the treatment regimen for hyperkalemia, which we'll go over at some point here in the slides. And then gynecomastia as a side effect of spironolactone, especially in males that are the ones that notice that, um, due to the anti-androgen effect. If they were to have that, uh, that side effect, you could switch them to a eplerenone in the test question, whatever the case may be. Usually in real life, you just kind of switch medications unless there was a really good reason you're on one of these. But either way, yeah, hyperkalemia definitely the most important. So there's a little picture here of the renal physiology as well as like where the diuretics work. We actually have something coming up here. Um, a little mnemonic, a little visual aid to remember this. And I believe was this your girlfriend, Mike, who made this?
Yeah, it was.
Yeah, she's brilliant. What can I say? So there you go. As you can see, like the Maltz mnemonic, kind of as you go through the tubule, you can see where those different ones act. Very high yield for step one to know where these act. Just based on the physiology of them because it's a way to highlight the receptor densities and the co-transporter densities throughout the nephron, which is a very step one friendly question. So we'll kind of move on quickly here to some nephrotoxic meds. The reason nephrotoxic medications are so high yield is because, you'll be giving someone a medication in a hospital or in the clinic, and then it would give you a reason to check their creatinine in the outpatient or inpatient setting and track that and be suspicious for it if you were to see an AKI in the setting of a medication. So we want you to have a good index of suspicion, even if it's not on this list. If you started a new medication and you have an AKI, there's almost an endless list of nephrotoxic medications. And a lot of times, what's your first step in those situations, Mike?
If there's a nephrotoxic medication, I
Yeah.
would hold it.
Yep, just discontinue the medication. That's a very safe answer on many exams. So we'll jump right into it. So acyclovir,
It
commonly
can
used in the setting of viral infections such as like herpes zoster infections or herpes encephalitis, stuff like that. What kind of nephrotoxicity do we see with that, Mike?
it can crystallize, so you can get like kidney
Very good.
stones essentially.
Yeah, very good. So specifically, I've seen it tested where they ask specifically about the pathophys and it being tubular obstruction by those crystals. So a crystalline nephropathy for the acyclovir is very high yield. How about aminoglycosides? A bunch of high-powered antibiotics with gram-negative coverage.
These cause direct like tubular necrosis, right?
Very good. So what would you see on your UA with casts?
Those would be the brown muddy casts.
Very good. So yeah, so this is a direct cause of ATN. The other main cause of ATN being like prolonged hypovolemia or poor perfusion of the kidneys for a prolonged period, but this one causing it. So in general, aminoglycosides, because of this effect and because of they have ototoxic effects as well, they're generally not first-line agents. They're usually reserved for people with either extreme pathologies, like it's kind of empirically indicated for infectious endocarditis, or it's involved with a lot of people who have like MDROs or multi-drug resistant organisms. So we'll kind of move on. One that I didn't really study that much, but is actually kind of gaining a little bit of popularity in the question banks. How about gadolinium? What is gadolinium, Mike?
That's a contrast agent, right?
Yeah, it is. For what studies?
Is this one for MRI?
Very good. Yeah. So gadolinium is the contrast used in MRIs. And what's the high yield side effect? It's actually a syndrome that you can develop after this.
Yeah, it's contrast induced nephropathy. I've talked to some radiologists about this. So It causes a combined like pre-renal and ATN type picture that typically peaks around what 48 hours, 48 to 72 hours after contrast.
Yeah, so this can cause the same thing as like what you the contrast that you would see like iodine-based contrast, which we'll go over in a bit with like CTs and stuff like this. But the thing I wanted to indicate specifically for gadolinium is this weird systemic fibrosis syndrome. So after MRI contrast, specifically gadolinium, you can develop this AKI that's really nasty with multi-organ failure as well as like characteristic joint contractures, almost like a systemic sclerosis type picture. So just something to keep in mind because it's just odd enough to find its way on exams, and just to keep it in your mind that like these scans, the same way with contrast with CTs, they're not without any risk at all. You know, it's not risk free to put someone in an MRI. So good thing to remember there. How about platinum-based chemotherapy? So this is things like cisplatin, oxaliplatin, things like that.
Yo, Andy's here. I'm using his rig. Andy, how do we reduce the risk of plant-based chemo nephrotoxicity? Is it hydration?
Yeah.
What else, Andy? There's a specific agent.
What the it takes as a specific agent to reduce plant-induced chemo. Is this the one where there's another one with but that's cyclophosphamide. That's
Yep,
the
and that's coming up, so don't spoil it.
oh, I don't even know if I remember that one. I don't know, Tay. We're stumped, man.
That's all right. So it's amifostine is the agent that you can give with this. Now, IV fluids are definitely the standard of care when it comes to preventing this. But amifostine is a specific, I believe it's a like an antioxidant agent that kind of prevents the oxidate like the radical oxidate oxygen species production associated with platinum-based chemo. So just something, once again, this is more of a step one question. I don't think I ever saw it when I was studying for step two, but it's like a specific antidote type question that is good to keep in mind.
I've never seen it,
Um,
but that's stuff they'd love to test.
they do, they love that stuff. But fluids in general, whenever you're worried about, nephrotoxicity, one of the best things you can do is make sure that somebody is hydrated. Because as you're dehydrated, you concentrate all of these agents, so any toxic effects are amplified by that. We just talked about this contrast-induced nephropathy. It is tested on exams. You talk to different doctors, you'll get different answers regarding, its mechanism and its actual existence. Some people do think that this is not a thing, but it is tested. So for us here at Strudel, it is a thing. The important thing that I've been tested on is that it's a combined mechanism, like Mike was saying. So both causing some vasoconstriction and direct cytotoxicity to have some sort of ATN type picture. So it's important to know that there's actually two mechanisms behind that. And like you mentioned, prevention with this is just pre-hydration. In fact, I'm pretty sure in most EMRs there's a order set for people with like AKIs getting contrast that would order a specific contrast pre-hydration regimen. So that's something to know. This one's a really tough one. How about tenofovir? So tenofovir actually is an anti like hepatitis C agent that's actually used in HIV treatment as well. So it kind of has some crossover. It's an antiviral. Any idea, Mike?
That's a tough one. Is it renal papillary necrosis?
No, it's not. That's a good guess though.
I don't know
Yeah,
though.
so this one specifically is Fanconi syndrome. So this is one of those other weird instances
I
of
have
type 2
seen this.
RPA causing anagma. Um, so it's due to bicarb excretion. It's just once again, these are very like niche things, but they'll really set it up in the question. You'll just have started antiviral therapy. They'll say that you started tenofovir and then you'll have an AKI. But looking at, expected lab findings, you expect non-anion gut metabolic acidosis with this one specifically. Then how about NSAIDs, the ever common NSAIDs and ever
Okay,
warned against?
so Fanconi syndrome, is that the one where patients have loss of like reabsorption of amino acids as well? It's essentially loss of reabsorption of everything in the proximal convoluted tubule.
I think that's correct. I think they do they waste those amino acids as well. But it's different than Fanconi anemia.
Oh, yeah,
That's
Fanconi
like
anemia is different. That's
yeah,
the one
that
that
Fanconi's anemia is like a pancytopenia type picture, I believe.
yeah.
It's like a congenital thing.
Yep. All
Yeah.
right. And
So
says
NSAIDs.
they reduce they inhibit COX protein cyclooxygenase. So you reduce production of prostaglandins. So you lose you lose the vasodilation of the afferent tubule, so you basically are inducing effectively AKI by reducing perfusion to the nephron,
Very nice.
but they can
Yeah.
also
So
cause AIN.
yeah. Yep, so that's good to know. AIN, it's one of those implicated along with like many antibiotics and stuff like that. But they cause AKI because they take away that vasodilatory effect of prostaglandin on the afferent arteriole. So you're just going to get less blood flow to the kidney that way. And then like I mentioned, a bonus because it's not really the kidney, but cyclophosphamide. What's its big side effect and how do we prevent it?
I know the side effect is hemorrhagic cystitis,
Very good.
and the side effect is man, I don't know the side. You'll have to tell me this
The
one.
prevention is mesna, which is
That's
basically a big old chelating compound, I believe is what it is.
yeah.
But it stands for like a big giant chemical name. I believe that is what that is. But also just a high yield situation. Cyclophosphamide used not really in a chemo context as much as in an immunosuppression context for people with certain rheumatologic conditions and stuff like that. So it does get tested quite often. So kind of going into acute kidney injury, we're going to kind of run through this kind of quickly because it's base knowledge, but it's not necessarily the testing situations that you'll need to know for exams. It's more for in the wards, kind of knowing what you're dealing with. So the definition of an AKI, Mike, what is the kind of criteria that usually gets at least pimped on and used mostly in the clinic?
I should really know this by memory now, but it's any increase in of 1.5 times baseline, and then is it 0.3 in 24 hours and point and or 0.5 in like 48 hours, and then there's one, and then oliguria as well. I don't know the
Yeah,
strict
so
definition.
so it's tough. The exact one, this is the KDIGO criteria for AKIs. So it's specifically has to be a rapid decline, an increase by zero point 0.3 in the creatinine within 48 hours, having 1.5 times your baseline within 7 days. And then, like you had mentioned, there is also a criteria for urine output specifically for oliguria, which is defined as less than 0.5 milliliters per kg. If you have new oliguria that develops within 6 hours, that would also be considered an AKI. So causes of AKI are broken up in general to pre-renal, renal, and post-renal pathologies, and we'll kind of go through some of these as we go. So just in general, just kind of rattle off some pre-renal etiologies for me, Mike.
So effectively, so pre-renal you would get anytime you have effective hypoperfusion of the nephron. So you can get that either with like vascular congestion, like in heart failure, or like cirrhosis, where you have effective intravascular depletion, or you could have hypovolemia as well. Sepsis as well would cause like reduced intravascular volume.
Very good. Yeah. So any pre-renal is basically anything that's going to decrease the effective circulating volume, or like you had mentioned, which is kind of is especially more high yield now. This idea of cardiorenal syndrome, which is basically congestion of the kidneys causing decreased perfusion. Um, so yeah, any prolonged hypertension, fluid overload states that leads to congestion or just decreased cardiac output in general, like in the setting of ischemia, like an ACS or something like that, where you can kind of experience that drop in perfusion of the kidneys. Specifically, renal etiologies, this is kind of the intrinsic issues. Large majority of them can be rheumatologic or interstitial in nature. ATN, which we mentioned earlier, is kind of an intravascular or an intrarenal, sorry about that, pathology, just because at that point the muddy brown cast that we're seeing are basically dead endothelial or epithelial cells of the tubules that are kind of being shed and molded to the shape of the tubules and then passed in the urine. But this includes our glomerulonephritides, our vasculitides, and then the interstitial disorders like AIN that are caused by meds. Infections can cause certain interstitial disorders, and then just other diseases as well that kind of cause that, like infiltrative diseases. So post-renal really kind of comes down to just a few. Um, your differential for post-renal is not very big. Either your intrarenal or right, like really close to the kidney. So this is like your stones or protein buildup where you can have, obstruction of the collecting system that way, as well as extra-renal being further down. So this is just any anatomy there in the urinary tract. So whether that's at the renal pelvis or in the ureter, in the bladder with stones, and in the urethra with strictures, all of those things, and especially the urethra in the setting of BPH probably being the most commonly tested. So if the prostate gets big, compresses the urethra, has outlet obstruction, you could see bilateral obstructive uropathy, as you would say. Um, I would say there, just having these differentials in your mind are important as you take these exams, and just kind of um, realizing based on somebody's past medical history what kinds of things they are susceptible to. So, if you have anything to add there, Mike, it's kind of just a content slide.
No, the main thing was just having a framework for any acute kidney injury, and that's the most common one. And the one I use is the pre-renal, intrarenal, and post-renal etiology. Pre-renal being any cause of intravascular depletion. Intrarenal can be either a glomerular cause or an interstitial cause or ATN, which is probably the most common. And then post-renal is anything obstructing kind of the urinary flow. But totally
Yeah,
agree.
very good. So, kind of talking more about acute kidney injury, just kind of some more building a framework. So, if you think you have a pre-renal um, acute kidney injury, what would be kind of your first thought or like consideration of a patient's situation? Like looking at a patient, what would you want to determine first? This is kind of a read my mind type of question.
I think I know what you're thinking. So that, with these types of questions, even when you get asked them as a student and especially on exams, usually the cheapest thing to do is go look at the patient. So the first thing I would do is, get a history, obviously, but then on exam, we want to see if they're fluid overloaded, check their fluid status, or euvolemic or hypovolemic, and that'll
Yeah,
give me a good
absolutely.
indication.
So, very important thing to be able to do when on the wards is assess a patient's fluid status and do that accurately. Um, Obviously it helps if you've been following a patient for many days and you're like, I know that their edema is getting better, they're becoming more euvolemic, or you're tracking their weights and they're back down to what you would consider their dry weight. I think they're more euvolemic now. But let's say you think that this person is hypovolemic. Maybe they have dry mucous membranes. They have a history that's telling you they're hypovolemic. They've been, having a lot of vomiting, maybe some diarrhea as well, like a viral gastroenteritis picture, something like that, where they've lost a lot of volume. What would your best next step be in if someone you thought was hypovolemic?
Give them some fluid.
Yeah. So the first thing you'll do in a hypovolemic AKI is just challenge them with a bolus. And the way I think about it is like, okay, if your problem is a lack of fluid, we'll give you a little bit of fluid and see if the kidney responds. If it doesn't, that usually means that maybe we need to broaden our differential. Like maybe you are hypovolemic, but maybe there's something else going on with the kidney itself, like an intrarenal etiology that's kind of leading to all this. And then what if you go and examine the patient, you see, they got crackles in their lungs and they have like 3+ pitting edema up to the mid thigh. What's kind of your next step?
Yeah. So, if there's too much fluid, then we often want to correct it with some diuresis, but would probably want to update an echo or check if they've ever had an echo done.
Yeah, very good. So not, obviously with hypovolemic and the bolus challenge, and then hypervolemic and diuresing in general. Obviously, there are other things to be considered. What's the origin of their hypervolemia? Do you believe this is cardiac in nature? Do you believe, do they have cirrhosis? Do they have, um, is this an AKI on CKD and you think that their kidneys are actually shutting down and that's why they're hypervolemic? A lot of things to consider there. But in general, if someone's hypervolemic with an AKI, you're kind of reaching to kind of get the fluid off and stop the congestion. So now you think it's intrarenal. So let's say maybe you thought it was a hypovolemic picture. You gave them a bolus, no response. Maybe they have some risk factors that would make you think intrarenal, such as like history of like autoimmune diseases, or maybe they're on a lot of medications and some of them can be nephrotoxic. Um, what's your, in general, what's the treatment for intrarenal AKI?
So, the first thing is to assess what would have caused an intrarenal AKI.
Yeah,
So usually the culprit is a medication. So holding anything that could be potentially nephrotoxic,
very
unless it's
good. Yeah, that's
absolutely
definitely a good
required.
place to start.
Um, Usually still there's can be a mixed intrarenal and pre-renal picture. So fluids can still help, but then
Yeah.
with intrarenal etiologies that almost always warrants further workup. So, first steps would be getting like a FENA to verify that it's an intrarenal cause. Obviously, you would want to obtain a UA, a urinalysis, and then any additional workup pending the results of that.
Yeah, so really the point of intrarenal pathologies is that really it ends up being supportive and you really get into the weeds of a workup for intrarenal pathologies. So you're really, you're stopping the nephrotoxic medication, see if that gets anywhere. Usually consider you're continuing the fluids. Um, let's say this person, maybe they have some known rheumatologic disease and you think that's what it is. That's when you start kind of reaching for your steroids, your plasma exchanges, ways to kind of clear those specific situations. But really the point is that a lot of it is now you're starting to look at different workups, whether that be for rheumatologic disease, nephrotic versus nephritic syndrome, which you kind of mentioned, going after the UA and starting to kind of get all of the information at your fingertips and start going into a diagnosis. And we'll kind of see some of those as we go on. Um, so let's just kind of get into some cases here. Um, and as well as we'll kind of talk a little bit more about just basic pathology, but really we're going to start getting into more of the caseload of these slides and making sure that we can identify patterns as we kind of go through. So, this is kind of a special case that actually gets tested quite a bit. So this patient, comes in, they're noted to have like tense digits. They have like a history of dysphagia. They have a history of hypothyroidism. And now they're presenting with this picture, their labs show a terrible AKI, like really big increase in their creatinine. And there's also like signs of MAHA, which would be like your microangiopathic hemolytic anemia, which would be like, signs of hemolysis. So like, elevated LDH, decreased haptoglobin, schistocytes on a blood smear if you get that on an exam, all that stuff. So what's your kind of preliminary diagnosis there, Mike?
So this sounds like to me a scleroderma renal crisis. So I think the treatment is really just ACE inhibitors. So I believe you start with a enalapril IV drip, and then you switch to is it captopril?
Yep, you're absolutely right on all accounts. So a scleroderma renal crisis, they'll give you kind of that manifestation. Usually they kind of go after some of the ones that are more well known with Crest syndrome. So whether that be like the sclerodactyly plus the esophageal dysmotility, history of like autoimmune diseases as well. And then yeah, the treatment ACE inhibitors, usually enalapril is the one specifically that's given as an IV drip. So you can kind of really quickly titrate that and adjust that. And then captopril, I believe, is either Q4 or Q6H, so you can also like more quickly kind of start messing with the levels of that. And as you guys will see as we kind of continue going through the renal section, ACE inhibitors and RAS inhibiting drugs in general have renal protective effect due to their dilation of the efferent arteriole. So that's always important to keep in mind. Okay, so now let's say we have a different patient. We have an AKI. This is kind of going back to the first question, like the first part of the slides here. If you think it's post-renal, um, what's your best next step? And like, what would you kind of see on an exam that would make you think it's post-renal?
Yeah, so in this case, the best treatment would really be to relieve the obstruction. So whether or not that's like BPH causing urinary obstruction, kidney stones, typically we want to relieve the obstruction either with like straight cath or lithotripsy, or something like that.
Yeah, exactly right. So catheterization is a very common answer on exams, especially, they might give you a history of BPH. Now they have a little bit of an AKI, you do it, they haven't urinated in X, Y, Z amount of hours. Going after the cath is a good idea. Also with stones can sometimes be a good reason that they go after a urology consult for nephrostomy tubes. So especially in the case, some people can get, in chronic like urinary stone formers, they can get bilateral obstructing stones and have bilateral hydronephrosis, leading to a pretty gnarly like post-obstructive uropathy. And in that case, you would need a tube to bypass that obstruction, which would be done percutaneous as a nephrostomy. So both those things, but as Mike said, you're really just trying to get away from the obstruction. You're trying to bypass it in some way. Um, so also kind of a niche question. What's the most common cause of death in AKI?
In an AKI, is it infection?
It is still infection, which I always wondered, why, how is this really it? But yeah, infection due to impaired humoral and cellular immunity associated with decreased renal function. It's kind of interesting. I kind of wonder if it's always like, how many people have or get septic and have an AKI with that. And that ends up being kind of the syndrome of like multi-organ failure that ends up happening with these patients. But in general, if they were to ask you the most common cause of death in AKI, it is infection. So also with AKI, we worry about uremia. This is like when we see somebody with their BUN levels like through the roof. What are we worried about with uremia? The side effects of uremia?
Platelet adhesion is impaired.
Yeah.
So it's a what is it? A qualitative defect with uremia.
Yeah, that's very high yield to know.
Also
Yep. So we're
things like
worried about bleeding. We're also worried about, like we mentioned, the immune dysfunction that can kind of be driven by uremia, as well as uremic pericarditis and uremic encephalopathy are both kind of the end organ damage results. But knowing that is a functional platelet deficit is very important. Your counts of platelets will be totally normal. So what if you see any of these? If you see any of these like end results of uremia, so they're having like a really severe GI bleed and they're uremic. They are having uremic pericarditis. They're uremic and they're encephalopathic. What's our next best step?
got to be calling nephrology for dialysis, right?
Yeah, so this kind of fits into our, it's always good to know the indications of dialysis, and we'll go through that on one of the slides. But knowing that these in specific are kind of the end organ damage associated with uremia, and you need to kind of, this is like the sign that you actually need to intervene. You can't really wait for it to resolve on its own. So definitely good to know. So now kind of moving into more renal pathology. So you have a 70-year-old male with a history of cirrhosis. He has worsening ascites and abdominal pain. Exam is significant for tense ascites and mild asterixis as well. His creatinine is 2.8, which is significantly increased from baseline, and his creatinine does not improve despite giving IV normal saline. So what's kind of the diagnosis in this situation?
Sounds like hepatorenal syndrome.
Yeah, so hepatorenal syndrome, obviously just tying together both, renal injury caused by hepatic disease. So what's the pathophysiology behind hepatorenal syndrome? Actually, a very high yield point.
Splanchnic vasodilation. And what that essentially means is that there is dilation of the splanchnic vasculature, which causes an effective intravascular depletion of forward flow and perfusion to the kidneys.
Yeah, very good. So you basically end up just having a bunch of congestion secondary to the splanchnic vasodilation and all the fluid kind of pooling in those veins. So next step in management on an exam if you have hepatorenal syndrome.
It's octreotide, right?
Yeah, octreotide, diuresis as well, and then kind of the niche one that isn't really tested but is kind of a maybe is vasopressin as well. And basically, the idea is that as you're reducing that splanchnic vasodilation, then hopefully with the diuretic, you'll kind of start pulling that fluid off. So, kind of what's the definitive treatment? Those are all kind of temporizing measures because obviously the liver disease isn't going to get any better in the cirrhotic patient that we're talking about. So, definitive treatment, Mike?
First vasopressin's ADH, right?
Correct.
Okay, yeah, and ADH in high doses kind of acts as a bit of a
Constrictor,
vasoconstrictor.
yeah. Yep.
Definitive treatment, liver transplant.
Yeah. So really an interesting point and also kind of a rough point. Without liver transplant, if you have a true hepatorenal syndrome not responding to your interventions, an estimated lifespan of 2 weeks. I've actually seen this in real life on the ward, somebody with, kind of end stage liver disease and was not eligible for a transplant due to his history. Um, and it really was like the lifespan from that point, it's an emergent hospice referral because you can justify a lifespan estimate of 2 weeks. So kind of a really morbid condition if you actually do have this in it. So it's kind of high yield to know about for that reason. So I kind of added in, it's kind of out of nowhere in this slide. So expected lab findings in pre-renal AKI. I kind of needed a place to throw this, and I wonder if I meant to put it on the other slide. But a classic question is kind of what you're expecting on your lab. So
Oh,
a BUN to
this
creatinine ratio in pre-renal disease, Mike.
greater
What
than
would that look
20.
like?
I would say this only gets tested on the exams and in real life has very little,
Yeah.
if any, clinical utility.
Yeah, I would say that in general, like, can you use it as a way to contextualize and kind of support your case? Yes, but there are much better ways to go about saying that somebody has a pre-renal AKI. Even I wonder if your physical exam in general is going to be more sensitive specific for pre-renal disease than this ratio. But in general on exams, they will not give you pre-renal AKI and then give you a BUN to creatinine ratio that isn't greater than 20. They're usually not going to do that because they know it's so widely taught. What about the FENA? So this is an interesting little calculation that you can do with some urinary studies. The fractional excretion of sodium. So what would you expect in pre-renal disease?
This is the FINA of less than 1%,
Yeah.
correct?
Yep. FeNO less than 1%. You could also, in patients, this would not really be tested um, outside. And I actually have a point on it later, so I'll kind of spoil it early. But if a patient's receiving diuretics, their sodium excretion is going to be artificially increased, like we mentioned with all the mechanism of action of those diuretics. So in those cases, you'd actually use the Fe urea as your surrogate marker. And there, if it's less than 35%, you'd be considered pre-renal. So what would you expect on your urine sediment? You have a pre-renal AKI. Um, what would your urine sediment? Would you see any casts?
Probably no cast, maybe some bland sediment. Is that the
Yeah.
word they typically use?
Yep. Very bland sediment. So you wouldn't quite see like just the pre-renal AKI by itself. You're not going to see the muddy brown casts and what have you. That's more of specifically to ATN. But if you don't treat a pre-renal AKI, so let's see, you say you had someone that's super dehydrated and you don't hydrate them, what's our complication renally?
It can progress to ATN.
Correct. So ATN, that's kind of your prolonged ischemia or hypovolemia picture. Just like I had mentioned before, this is the tubular epithelial cells actually dying and sloughing off into the tubules. That's what we're seeing with those muddy brown casts. So and then, like I mentioned before, if they were on a diuretic, FeNA does not become useful. It becomes artificially elevated. So you would want to get an Fe urea instead. So they're all calculations. That's MD Calc for you. That's just a good place to use those things. And this would be a good way. You would want to get those studies, like especially on the wards, before you call nephrology about your patient's AKI that you're not making any progress on. You'd want to have these kind of studies ordered for them. So just something to keep in mind for the wards. So there's some casts here for you. Obviously, our muddy brown up here in B. And then the two that are the most important are going to be B, the muddy brown, and then D, the red blood cell cast. I believe we have like white blood cell casts, and then I think this might be the fatty or Highland cast, and this is the white blood cell cast, I believe. Um, and the fatty Highland cast is kind of a non-specific finding, can be seen with like nephrotic syndrome or just like as part of that bland sediment. Every once in a while, you can get that. The white blood cell cast, very specific for like pyelonephritis. Then we talked about muddy brown and then RBC cast for glomerulonephritis, muddy brown for ATN. So just kind of keeping in mind that they can test these pictures. So I would definitely look those up and be familiar with them on exams. Anything to add there, Mike?
Yeah, I'm gonna verify which one is which. I think the white blood cell cast is
I think
the,
it's this. You think it's C?
let's see. Yeah, I think the white blood cell cast is let's see. I found a picture. Let's see. So yeah, you're right. White blood cell cast is C.
Oh, really? I thought that was fat.
No, those are white blood cells. So
Okay.
yeah, obviously, so as you can tell, it's hard to differentiate, but
Yeah.
essentially the brown, anytime there's brown casts, it is almost always the brown muddy brown casts. And if they're all red, then it's red blood cell casts, and you see cells. And then if you see cells that are circular, it's the red blood cell cast. Because the fatty one is also called like the waxy cast. So
Oh,
it's
that's
kind of
right.
like a
Yeah.
non-specific, yeah, cast.
Yeah. So I would definitely know Muddy Brown and RBC cast because they can kind of point you in a specific differential. So some more rapid review cases here. We got a 30-year-old female is being evaluated for fatigue and a diffuse maculopapular rash. You're welcome for the dermatology there. Developed 2 days ago. She recently completed a course of antibiotics for a sinus infection, but otherwise she's healthy. Labs, she has a creatinine of 1.9, probably elevated from her baseline. Her UA shows many white blood cells, 1 plus proteins, some RBCs. So what's our likely diagnosis here?
Um, is this acute interstitial nephritis?
Yeah, very good. So the classic finding on that UA there, we have a lot of white blood cells, but no infectious markers. That's what we would call sterile pyuria. The other high yield thing, if they do it on the EUA for you, will be eosinophils in the urine. If you have eosinophils in the urine, very likely this is AIN, and that's what they're going for. Basically, an allergic reaction to these medications causing an interstitial pathology in the kidney. So, what are the other common clinical features of AIN? What else might you see on exam? Kind of non-specific, but go ahead.
So the big one is fever. Fever is like very commonly
Yeah.
seen. And then arthralgia is another one that I've seen.
Yeah, so fever, arthralgia, the eosinophilia, both in the urine, but also in the serum as well. And then the rash. It's probably rather non-specific. I can't speak to it from a derm perspective, but I think it is kind of a polymorphic type rash where like it's not necessarily always hives. It can be kind of non-specific. Am I right saying that, Mike, or am I totally off?
Yeah, it's not necessarily like a hive. It's similar to like a drug-induced rash. So
Mm,
in that case, drug rash can take a lot of different forms, but essentially, honestly, maculopapular is actually a pretty good description, but it's kind of a more biliform and confluent rash. But kind of if you see diffuse redness and pinkness,
yeah,
then that should, and they recently started medication that could tip you off to a medication induced rash.
yeah, that's a pretty good point. Treatment, what would you do?
Usually just stopping the offending agent and then supportive cares.
Yeah, and then just keeping in mind if you needed to, you could go to systemic glucocorticoids because in the same way an allergy response can respond to steroids. But the right answer on the test, 99% of the time I will guess would be discontinue the offending medication. Often it'll be antibiotics, but it's whichever one they give you in the question. Like I mentioned kind of earlier in the presentation, a lot of medications can cause this condition. So basically whatever they give you, just tell it to discontinue it. Alrighty. So 20-year-old woman presents to the ED after experiencing 5-minute seizure, generalized tonic-clonic. Urine sample collected is dark brown. Her UA shows trace protein urea 3 plus blood and 1 to 2 RBCs. So what's going on with this woman?
So it sounds like she had a seizure
Yeah.
and now has myoglobin in her
Yeah.
urine, and you can tell that because of the frank blood by or the microscopic hematuria, but only 1 to 2 red blood cells is the bit of discordance.
Yeah.
So that sounds to me like rhabdomyolysis secondary to myoglobin release after a
Very good.
seizure.
Yep, that's exactly right. So myoglobin is nephrotoxic, and in fact, it can cause this discordance, which is very high yield. So you're like, oh, this person has blood in their urine, but they only have 1 to 2 red blood cells. That doesn't make sense. Well, the UA specifically look at the globin group. So the myoglobin will trigger that UA 3 plus blood the same way as hemoglobin would, but the RBCs will be low because there's truly not red blood cells. This is just the pigment from the muscle that's breaking down. So AKI in the setting of seizure is very suggestive of rhabdomyolysis. But you could also, in some cases, if they can go after other causes of rhabdo this way. So this is like crush injury, and then you have these findings, or sometimes you can get statin rhabdomyolysis, which they might go after. But I would say most of the time it's crush injury or seizure for the most part for rhabdo. So what would you expect as far as her lab findings in the setting of rhabdo? Kind of just an off renal point, but go ahead.
Yeah. I would say anything electrolyte related can be renal
Yeah.
related. You can tie those in. But so, when you have muscle injury, you essentially get necrosis of the muscle cells, so they release their intracellular contents. And like as we remember, the salty banana, the inside of the cell is more potassium filled, the extracellular space is more sodium filled. So they'd have hyperkalemia, hyperphosphatemia, and then since phosphate binds calcium, hypocalcemia, and their CK would be markedly elevated, like greater than thousands, even maybe
Yeah.
even greater than like 10,000.
Absolutely. So right on the money there, you'd see the elevated CK along with those electrolyte abnormalities. Once again, this is just a good way for them to test hyperkalemia and what you can do about it. What would you expect your BUN to creatinine ratio being here?
So your BUN to creatinine ratio would be like less than like 20 to 1.
Yeah, so this is technically myoglobin is directly nephrotoxic. So this would be an intrarenal type look to it, similar to ATN. And then your FeNA, then what would that be?
This would be greater than 1%.
Yeah, greater than 1 or 2% is used the line for intrarenal sometimes. So, what would you expect on your urine sediment if they were to give you a report of the casts?
Here you would see muddy brown cast, right? This is directly
Yeah.
nephrotoxic.
Specifically, yeah, a lot of times it'll be worded a little bit differently because they won't want to confuse you and make you think it's ATN with muddy brown. So they'll say pigmented cast because myoglobin is pigmented. So it will cause that. And then what's your management of rhabdomyolysis and the associated AKI?
Usually, first making sure you know what the underlying cause is. If it's like, daptomycin classically has a high yield association with rhabdomyolysis, or if it's seizure. So, stopping whatever is causing the rhabdomyolysis, and then fluids, and then supportive management. So managing any electrolyte derangement.
Yeah, very nice. So really just going to be supportive care, fluid electrolyte monitoring and treating accordingly. Um, So kind of another high yield situation here. A patient has gross hematuria, so they're seeing blood when they urinate. Obviously, you verify this in clinic and see that they have gross hematuria in their urine sample. So what's your first, even when you get this history, like they're peeing blood, what is your first step in management?
The first step I would get is a urinalysis.
Perfect, because this is what we're going to kind of go into is like what is the UA providing in terms of the etiology of the bleed. So this is telling us like are we dealing with a glomerular source or a non-glomerular source, maybe an infectious source based on what the other markers in the urine are. So for example, if you see RBC casts on your UA, you're concerned for like a glomerulonephritis type picture, whereas a UTI, a simple garden variety UTI, can cause hematuria. So if you see, positive leuks, nitrites, and white blood cells along with bacteria, then you kind of move your differential that way. So it really does allow you to kind of go that way. So as far as your next step, let's say actually you think it's a glomerular cause, what would you expect the UA to show you? And I've kind of said this throughout the presentation.
So you'd see like many red blood cells,
Yeah.
maybe a few leukocytes, but not as much. Probably negative leukoesterase. Not
hmm
not really an infectious picture.
Yeah. So big thing as far as glomerulonephritis would be the RBC casts, but also like if it is glomerular in nature, usually you have these dysmorphic RBCs. Whereas if you have something in a non-glomerular cause, like such as a stone, that's causing, blood coming from, the stone nicking things while it's bouncing around in there. So those would be like, normal red blood cells rather than dysmorphic cells that are getting squeezed through an inflamed glomerulus, is the way I think about it anyway. So let's say you did find RBC casts. What's your next step when you see RBC casts? Kind of where do you go from there differential wise?
So RBC cast basically always indicate or should be very concerning for an intraglomerular cause. So, usually at this point, you start to get worried about what would be causing uh, glomerular pathology. So that would be like your rapidly progressive glomerulonephritis. Vasculitis can sometimes cause that. There's like
Yeah,
a cat climbing on my chair. But then, so getting some serology and then renal biopsy.
yeah. So you're basically it kind of does localize it to more intrinsic disease, so you kind of start that workup accordingly. We already kind of mentioned this. If it's non-glomerular, you'll have the normal shaped RBCs, no cast proteinuria, a negative culture. You'll kind of be dealing more with like some kind of mechanical bleeding. So, as far as next best step, if you think it's a non-glomerular source of bleeding, this is where so you think there's something whether um, it's stones or some kind of trauma or one of the really high yield points that we'll have a case on a little bit later. Um, there's something mechanical going on. So really, the next best step if you have non-glomerular findings is base it on the history and your patient, what risk factors they have. But really, it's going to be imaging. So whether that's ultrasound in patients that need that, a non-con CT is your ideal imaging for stones, a CT of the abdomen pelvis if you think there's some sort of trauma, like maybe an organ lack or like I've seen a lot of tested 11th and 12th rib fractures, causing a kidney lac and bleeding that way. And then probably the most high yield of them all, honestly, it comes up all the time, is doing a cystoscopy in patients that are at risk for bladder cancer. If you have gross hematuria in somebody, old smoker, um, it's kind of a weird, you kind of have chronic, progressive, weird hematuria and urinary symptoms. Getting a cystoscopy and evaluating for bladder cancer is not a bad choice in those patients. And then, like I mentioned also before, if there's UA findings consistent with infection, then that kind of changes your differential. So if you have the lukes, the nitrites, or the nitrates, and a positive urine culture, obviously, then that kind of ties you into a UTI causing it, and you treat that accordingly. So you just treat it and follow up. Some patients with UTI need a test of cure, most do not. Mike, what would a population be that needs a test of cure after they get treated for UKI or for a
Like
UTI?
pregnant patients have to be
Yeah,
treated for
absolutely. So
test of
UTI,
cure.
so pregnant patients with the UTI will get close follow-up. And then a lot of times, um, they worry about pyelonephritis. So you want to make sure that that's not occurring. If you do have pyelonephritis, I think that a lot of pregnant women get put on antibiotics, suppressive antibiotics for the remainder of the pregnancy because of the mortality associated with pyelonephritis in pregnancy. So just a little tidbit there. Um, so kind
Um,
of this is exactly the case. So we'll kind of skip through it very much. I've said this is very high yield. Getting a cystoscopy in the patient that is high risk for bladder cancer, as you can see, vague urinary symptoms with painless hematuria, specifically painless. You get a UA, it shows blood, but it doesn't show any sign of infection, inflammatory, things like that. Getting a cystoscopy is very high yield. The risk factors, like I'd mentioned, is smoking, the aniline dyes, cyclophosphamide, which we mentioned earlier with hemorrhagic cystitis, can also cause bladder damage. But kind of a high yield point, especially for this case of step one in pathology, is that schistosomiasis, which is the flatworm that's kind of associated, I believe it's with Middle Eastern geography, um, can cause squamous cell cancer of the bladder, whereas most other things cause adenocarcinoma. So if you were to see a squamous cell cancer of the bladder, they might be trying to test you on schistosomiasis. So what's the treatment for schistosomiasis, Mike? How about that callback?
oh man, is it like praziquantel? Is it that the
Oh yeah, it
one?
is. Yeah. Very good. Praziquantel is the treatment for that. Just a little. That's very step one-ish. Hematuria, just kind of keep continuing to go through a differential for hematuria. So now you have a 70-year-old male presents with evaluation for blood in the urine. Um, no dysuria, urgency, frequency, anything like that. No abdominal pain, fevers, or chills. There is a painless, palpable mass in his right flank. The UA shows greater than 3 RBCs per high-powered field. Trace proteinuria, no lukes or no nitrates. So, what are you kind of worried about in this patient with hematuria? And it seems like a right flank mass.
Probably, I'd be concerned about renal cell carcinoma. The other thing that I would consider is like a polycyst or renal cyst.
Yeah, exactly. So really either way, obviously the thing we're trying to rule out is renal cancer, renal cell cancer being the most common of the primary ones there. Risk factors for RCC, Mike, can you rattle a couple up? What's the most high yield for the
Yeah,
cases?
the most high yield is smoking, and the
Yeah.
most common etiology or the most common like pathologic diagnosis of RCC or subtype is the clear cell adenocarcinoma, I believe.
Yeah, so the clear cell RCC is definitely the most common. Smoking, and then also a very, very high yield syndrome to know about it is VHL syndrome. So this is kind of a combination. You can see like cerebral hemangioblastoma, specifically bilateral RCC. If you were to see bilateral RCC, anytime you have something, that is bilateral in nature, it raises a lot of questions for something hereditary. It means that there's probably some germline mutation making both sides as susceptible to that, because it would be just really terrible luck to get bilateral RCC spontaneously. And the reason VHL syndrome gets messed with a lot is because of pheochromocytoma. So a lot of those patients, sometimes you would diagnose this RCC, um, maybe they have a positive family history for it, and they would say, what do you want to do prior to trying to go after the resection for the renal cell cancer? Well, you'd want to check their plasma metanephrines. You'd want to make sure that they do not have an active pheochromocytoma, because that would complicate operative management. So just another way that you have to be able to build your mental frameworks off of how they can ask these questions. So you have RCC, then they add in the genetic component, then they're like, well, what should you look for, and how would you go about how would that change your management? So keeping that in mind. But either way, next step, you think this person has renal cell cancer. What's your next best step?
Um, I think you can diagnose with ultrasound, but likely a CT scan would
Yeah.
be warranted.
Yep. Usually, if you're suspecting cancer, a CT scan is usually the right answer. Um, what's important to note, though, especially with the kidneys and with other organs as well, there's a very high prevalence of incidentalomas that end up just being benign cysts that you would not have otherwise found. So it's important to know that usually you don't end up working up these cysts if they're not suspicious. So, for example, if someone were to have trauma and then you see a renal cyst, but like I have listed there, suspicious features, if they are less than 1 centimeter in size, if they have nice regular walls, they look very homogeneous in nature, no calcifications or irregular borders. A lot of times those are, kind of observed, or, maybe they put you on a tract for, we'll re-CT in one year or something like that. But if it is a simple cyst, it makes your next best step reassurance, which is very high yield because that's a very common test answer. But if you do have those suspicious features, um, you would want to stage it using your CT, but would you, what would be kind of your confirmatory test if you have something you think is a kidney malignancy?
I don't totally know if you just biopsy it or if you go straight for resection.
Yeah, and that's a very good thought. I'm glad you're thinking that way. So, partial versus complete nephrectomy is the standard. We're doing a lot more partial nephrectomies now than we used to be. For a long time, there was a lot of like hesitation to do um, partial nephrectomies for fear that you would leave some behind. And I don't know if like the technique or what it is that caused that, but we're able to do a lot more partial nephrectomies now. But the same way as many of these abdominal cancers, we don't want to try to biopsy it due to risk of like seeding the peritoneum. So same thing as you look at your germ cell malignancies with testicular ovarian cancer. You want to avoid biopsy there as well. You just go straight to taking it out. So that would be your confirmatory and both diagnostic and therapeutic treatment. So good to know there. So just kind of going into one of the more high yield differentials there, just a lot of information, but nephrotic versus nephritic syndrome. When someone says nephrotic range proteinuria, they're referring to greater than 3.5 grams a day on a 24-hour sample, or greater than 3.5 grams per gram on a protein to creatinine ratio, which can be done as just a spot ratio. Typically, these patients have 3+ proteinuria or greater on the UA. This is one of those cases where you can get fatty or epithelial cell casts, kind of non-specific, but nephrotic syndrome can have it. And then obviously you'd expect it to present with edema or anasarca because you're decreasing the oncotic pressure, you're wasting protein. As opposed to nephritic syndrome, you can still have proteinuria, but usually it's out of the nephrotic range, so less than 3.5 grams a day. You'll have more hematuria, and then red blood cell casts are kind of the pathognomonic feature for nephritic syndrome in general, specifically more so for glomerulonephritis, but that's more of kind of one of the main things that causes nephritic syndrome. So good to think about that in general, and we'll kind of go into some cases in our management for that. So let's say we have an 11-year-old female, history of a recent URI. She presents for evaluation of periorbital and lower extremity edema and fatigue. UA is significant for 4+ proteinuria, no RBCs, no CAS. So what do you think's going on here, Mike?
Oh man. So it begins. I feel like these are always pathologies that I struggled a lot with as a med
Yeah,
student, and I get a lot of questions about. I think this one is most consistent with minimal change disease. It seems like to me a nephrotic syndrome with the nephrotic range proteinuria, no evidence of glomerulonephritis, and I know that the most common cause of nephrotic syndrome in the pediatric population, especially after URI, is minimal change disease.
yeah, very nice. Um, would you need to biopsy this patient?
I would not. I think I would make a clinical diagnosis.
Very great. Yeah. So, and minimal change disease, it's a clinical diagnosis in children. Um, Pathophysiology, like Mike had mentioned, is a nephrotic syndrome. The buzz phrase would be effacement of the foot processes due to cytokine mediated damage, usually post infection. So, recent URI is a very common way to test this. And treatment can be done empirically. How would you do that, Mike?
Typically in the pediatric population, this responds pretty well to steroids.
Yeah, so this is one of the few actual like kind of nephrotic syndromes that responds to steroids very well. There are obviously other nephrotic syndromes, but they usually don't respond as well as minimal change does. So usually they can treat empirically with steroids and kind of monitor it, and usually this kind of self resolves with time. So in contrast, now we have a 40-year-old white female, history of chronic hep C infection. She presents with periorbital edema, weight gain, and fatigue. UA shows nephrotic range proteinuria without RBCs and casts. Blood pressure is a little bit high. They get a renal biopsy on her, and it shows like the glomerular capillary walls appear thickened. So what's your diagnosis here? Big demographic points in
Yeah,
this.
you gave me a lot of hints. So the chronic hep C infection, and then really with the path findings, theoretically we should be able to get the diagnosis from that alone. But sounds to me like the membranous nephropathy with
Yeah.
is more common in adults and is kind of similar to minimal change disease, but is a isolated nephrotic syndrome, more common in adults, especially with hep C.
Yeah, specifically in Caucasian adults, and then there are all of these like weird etiologies, and they kind of play into how they like to test off of it. I would say the most specific is Hep B and Hep C. So the next best test in this patient, obviously we're given that she has chronic Hep C, so that's fair. But if she had not, and you get the renal biopsy and you have membranous nephropathy, that would actually be an indication to go after screening for hepatitis, because obviously there are things we can do about that now. So. Um, Doing that might be a good exam question. Like, what would your next best step be? And it would be screening for the thing that might be the etiologic, the cause of it. So just
Yeah.
really quickly, what's the differential diagnosis? Like a few differential diagnoses for nephrotic syndrome in general. So just throwing out the kind of full gamut of nephrotic syndrome causes.
Yeah, going back to the membranous nephropathy, I've actually
Yeah, go
seen the
back.
cancer screening tested multiple times. So that's
Hmm.
also really high yield to know, and something I don't always think about when I see membranous nephropathy.
Yeah.
So differential for nephrotic syndrome. So minimal change disease, most common in pediatric population. Membranous nephropathy, more common in adults. Um, those are some of the main two I know, honestly.
Yeah.
Um,
So just
yeah,
to kind of
what
go
am
through
I
the
missing?
whole range of them, because it's high yield to have these all in your mind. And there are some cases I have
FSGS is
familiar,
one.
but yeah, FSGS is the other one. Diabetic nephropathy is technically it can cause a nephrotic syndrome, and that's obviously very common. And then amyloidosis and myeloma are kind of the more like anomalous, kind of mysterious causes of nephrotic syndrome that would kind of be found on a more detailed workup. So kind of going into more of the primary glomerular disorders, 29-year-old female for evaluation of hematuria, recently recovered from a cough and runny nose 2 days ago. UA shows 3 plus RBCs, 1 plus proteinuria, and RBC cast. So here's a patient that we believe to have um, nephritic syndrome. So what would our most likely diagnosis be in this patient, Mike? What do you think?
Yeah, this is sounded to me like IgA nephropathy. I think it was called Berger's disease in the past.
I think Berger's disease is that thromboangiitis obliterans in your fingers, isn't it? Or is this one Berger's disease too? Is it both? Are they both Berger's disease? I forget.
Yeah, they're spelled different. This is the one that's Berger, and the
Yeah, I
one
think
that
you're
you're
right.
talking about is Buegr.
Yeah, it's been a while since I called it that. Yeah. So Warburg disease, but IgA nephropathy, um, especially considering the recent history of infection, as we know, especially mucosal infections. It sounds like this woman had a URI, um, so we would have a proliferation of IgA in those circumstances. Um, so expected findings on electron microscopy, very difficult question here. I wouldn't know this.
It'll be here we go. Maybe IgA deposits on the subendothelium. It's like the border.
Yeah, so mesangial deposition of IgA and C3, very good. Step one, it is good to know the patterns and the things, the ways that they would describe it. So with membranous nephropathy, like we just mentioned, the spike and dome appearance on biopsy, as opposed to here, which would be kind of a more like linear mesangial deposition. Um, so kind of a very high yield point is contrasting this with PSGN or post-strep glomerulonephritis, or PIGN, post-infectious glomerulonephritis. So the big thing to know is that PSGN obviously is going to occur after strep infections for the most part on exams. So whether that's strep throat, which is usually more of a children's disease, um, if they give you a positive ASO or DNAB titer, um, or if you have a strep pyogenes skin infection, like impetigo on top of an atopic dermatitis or something like that, that can kind of push that. But the really high yield thing that I want you guys to know is the lab that can differentiate IgA nephropathy from PSGN. And what would that be, Mike? Do you have any idea?
The lab that would differentiate IgA nephropathy from
Other than the
PSGN.
ASO titer and DNase titers, which would do that. But
Oh man, it's gonna be. Is it something like board specific? It's something super specific. Oh man. I mean, and other than C3, I guess you get C3 deposition in both.
you do,
Um,
but specifically PSGN is associated with hypocomplementemia. So
okay.
typically IgA nephropathy is going to have normal complement levels. PSGN is going to have low levels. So because in reality, if this case were an 18-year-old with RBC casts and dark urine and recently had a sore throat, it could easily be either one of these. And the complement level would be something thrown on the initial workup to kind of see, is this post strep or is this IgA mediated? Um, so just a very like high yield thing to tell apart two very similar presentations. So I would keep those in mind. So just a little bit of rapid fire, and I don't know, Mike. This session is pretty long. I'm not gonna lie. We might kind of call it after this is about halfway through the slides. If you want to keep
We're only
going, go ahead.
halfway.
What do you
That's
think?
crazy. I mean, it's up to you. I mean, we could probably finish it
All
if
right,
you
I'm on. This
get.
is slide 20 of 44, big dog.
Holy crap. All right, we'll finish it tomorrow.
All right, sounds good. I'll try. We'll make time for it. So some renal
Oh, that's
rapid
right. You're
fire.
doing stuff tomorrow. We can
No,
finish it
but
like,
only for 1 hour though. Only for 1 hour though. I'll have time.
okay, we'll finish it tomorrow.
Yeah. So some renal rapid fire. We'll kind of finish out the slides here for at least this part of the session. So nephritic syndrome, and they have eye problems, and they have sensorineural hearing loss. Where's your mind at, Mike?
Is this Alport syndrome?
Yes, it is. And what's the defect in Alport syndrome?
Oh man, Alport. It's like a glomerular basement membrane disorder.
Yeah, it is. And specifically, it's type 4 collagen, which is used in all of those areas, both in the basement membrane of the glomerulus, in the membrane, in some of the inner ear organs, and then in the eye as well. Type 4 collagen is needed there. So now you have a 40-year-old woman, history of hypothyroidism. She has a rash on her face, arthralgias, and now she has nephritic syndrome. What are you thinking?
It's lupus.
Yeah, it's always lupus. And how would it stain on pathology?
Oh man, you would get C3. You would get complement deposition,
Yeah.
and you would get. Is this? It's like subendothelial. Um.
Yeah.
Oh, is this the wire track? This is the wire track, right?
I don't think so. I think that's membranoproliferative, which lupus can cause membranoproliferative. But just in general, the thing that's kind of high yield to know is that I've heard it described the full house staining pattern. So it literally lupus, like a full-blown lupus nephropathy will stain positive for everything. That's like CG, like C3, C4, IgA, all these things. The IgG, IgM will all stain positive on some of these patients. So if there's ever a question saying like which ones would you expect to be positive in lupus specifically, it can be full house where everything stains positive. How about a 45-year-old with HIV doesn't take their ART, their antiretroviral therapy, and now they're exhibiting tons of proteinuria, have like features of anasarca. What are you thinking here, Mike?
This HIV nephropathy.
Yeah, exactly. Specifically, it's a variant of FSGS. Do you remember the name, the term for the specific subtype of FSGS associated with HIV?
I don't.
Yeah, so specifically the collapsing variant of FSGS, somewhat high yield, but in general, it's referred to as HIV-associated nephropathy. So very good to know because they love testing complication of HIV, and this is the way it affects the kidneys with a nephrotic syndrome, specifically like a family of SGS. So now you kind of brought this up earlier, Mike. 25-year-old with sickle cell, and they have flank pain, hematuria, and then you do an ultrasound, and you see specifically very very good description, increased medullary hyperechogenicity.
Oh man. Is this renal papillary necrosis?
That it is, yeah. So complications of sickle cell also very high yield. Um, and this one specifically, the hematuria. This is usually renal papillary necrosis is more in full-blown sickle cell disease. Sickle cell trait is more associated with the finding of like hypostenuria.
Hypostenuria. I think that's more related to chronic micro infarction of like the renal papillae, and it basically causes an inability to concentrate
Concentrate. That's
urine.
right. Yeah. So that the hypostenuria, yeah, I'm sorry, I kind of confused the people there. So renal papillary necrosis will have the hematuria. Hypostenuria will have a really low specific gravity on the UA, due to like like a deficiency in concentrating the urine. So both of those are very high yield to know. And but usually renal papillary necrosis goes with a full-blown sickle cell disease, and hypostenuria is like more seen with sickle cell trait, so more of a mild clinical picture for them. So now you have a 30-year-old female, increased urinary frequency and pelvic pain relieved by urination. Cystoscopy shows inflammatory patches on the bladder wall. What are you thinking, Mike?
Oh man, this is difficult.
This is a weird one. Yeah.
Inflammatory patches on bladder wall. I mean, the first thought I had was like cystitis, but
Yeah,
I
yeah,
don't.
you're exactly right. Specifically, this really weird condition that's getting tested more often because we're finding it's more common. It's actually causing a lot of problems, and we didn't really like know much about it. This interstitial cystitis. The specific part of this presentation is the pelvic pain relieved by urination. The cystoscopy showing inflammatory patches. There's also like fibrin deposits and stuff like that, are kind of characteristic of the disease. So definitely something to keep in mind, um, because it is actually kind of a distressing syndrome, and it was kind of underdiagnosed, I think, and it's kind of rising in popularity on exams. So we kind of talked about this earlier. Pregnancy is a very good renal population to know about, because there's things we do a little bit differently than the normal population. So the pregnant woman, she gets a routine UA and it shows bacteria, but she's totally asymptomatic. What's your next best step?
Treat it.
Yeah, you got to treat it. So pregnant people and people getting urologic instrumentation or urologic procedure are the only people in which we treat asymptomatic bacteriuria. Otherwise, if you or I, roll off the street, give a urinalysis, and there happens to be bacteria in our urine, we're totally asymptomatic. We're not going to get antibiotics for that. But if it is symptomatic or if it is in these populations that I just mentioned, we got to treat. And our first line agents, for the most part, phosphomycin is starting to become a lot more popular on exams. Um, Bactrim and nitroglycerin, don't do that. Nitrofurantoin, um, have some different windows that they're used. Depending on like what time stage you're in pregnancy. So Bactrim, if you're more in the middle of pregnancy, nitro's okay unless you're close to the due date. Second gen cephalosporins are also becoming more used as like first line agents in like UTI pictures also. Phosphomycin is really good, and it's safe in pregnancy, but I think it is a little bit more expensive than the other agents. So usually nitrofurantoin or Bactrim are still typically the choices. So keep those in mind. Let's say you made a big mistake. You didn't treat this woman's UTI, and then you have fever, nausea, vomiting, and flank pain. So now what happened, Mike?
I'd be worried about ascending pyelonephritis.
Yeah, very good. So what do you do for that patient? Pregnant patient with pyelonephritis, what do you do?
Oh man, they'd probably need IV antibiotics, maybe like
They do, yeah,
cephalosporin. I would start
absolutely.
with.
Yep. You're putting them in the hospital and you're giving them IV third generation cephalosporin. Like I mentioned before, the mortality associated with it, and just the increased risk of like severe presentation, premature labor, all these things are reasons to go and get the IV antibiotics. Also, just in general, if you have nausea and vomiting and you're not able to tolerate oral intake, expecting them to go home and take their pills and keep them down is kind of a big ask. And then, like I had mentioned kind of earlier in the presentation, at some point, you can do like nitrofurantoin for the rest of pregnancy, or just like monthly surveillance UA and culture. There's some different ways of going about it, but the big thing is once you've had pyelonephritis, our index of suspicion for recurrent UTIs and pyelonephritis is very high in these pregnant patients. We just don't want them to kind of be exposed to that risk. So yeah, that's the last one of the little renal rapid fire to kind of end off the presentation. Um, we'll kind of start up the next section, with some very high yield cases that are very specific. scenarios, kind of similar to these rapid fire cases, but that need to be discussed in like the next best step format, just because there are very important differentials to be had when it comes to these next few cases. So definitely come back, stay tuned for part 2 of the renal review.
Yeah, sounds good. We'll do part 2 and upload that shortly. Last thing about pyelonephritis and treatment, I often used to get confused by the antibiotics, and just know that nitrofurantoin accumulates more in like the bladder, so it can't be used to treat pyelonephritis. Really, you got to use a IV cephalosporin or something like that.
Yeah, that's definitely a good point.
All right.
All
Thanks
right.
everyone for listening. We'll upload part 2 shortly, and it'll be linked. So we'll just upload this in 2 parts because it's getting to be a long video.
Yeah, fair enough.
All right. Peace.
Peace. Mike, we got to make shorter videos, man.
Yeah, dude.